Well, good evening, everyone. Welcome to the Crohn's and Colitis Foundation's Facebook Live program, COVID-19 Updates. My name is Catherine Soto. I am the Senior Director of Patient Education and Support at the Crohn's and Colitis Foundation. And as we continue to learn about COVID-19, IBD patients and caregivers are having a lot of questions about how it may affect them and what precautions they should take moving forward. With updated guidance from the CDC and the FDA regarding additional doses, boosters, and the recent approval of the Pfizer vaccine, we will aim to answer questions from the IBD community about their concerns. So I want to welcome tonight's presenters. First, we have Dr. David Rubin, who is the chair of the Foundation's National Scientific Advisory Committee and a gastroenterologist at the University of Chicago Medicine. We have Freddie Caldera, a gastroenterologist and IBD specialist with the University of Wisconsin, and Dr. Mina Butra, gastroenterologist with the University of Pennsylvania. Thank you all for joining today.
Happy to be here, Kat. Thank you.
Yeah, thank you.
Well, before we do get started, let's go over a few quick pieces of housekeeping for our audience. The information provided during tonight's chat is meant for educational purposes only. It should not replace any advice you receive from your gastroenterologist, nutritionist, or surgeon. If you have questions about your specific care, please reach out to your healthcare provider. If you have questions about IBD unrelated to COVID-19, we won't be able to get to them tonight, but to get your questions answered, you can always feel free to contact our IBD Help Center by calling 1-888-MY-GUT-PAIN or emailing info@crohnscolitisfoundation.org. We asked our followers to send in questions in advance of today's discussion, and I will go around and ask our presenters to help answer these questions. So, Dr. Rubin, let's begin with you. Can you remind our viewers about the FDA process for reviewing and approving vaccines? What's the difference between an emergency use authorization and an approval?
All right, well, thanks, Kat. Let me welcome everybody tonight. And obviously, it's been a turbulent 18 months. We all recognize that, and it's been hard for people to keep up. And especially in the inflammatory bowel disease community, we know of the concerns people have based on their conditions and based on the therapies they've been on. So I'm very grateful for the opportunity to join my expert colleagues and friends tonight to try to address some of these questions. So to get to the issue of FDA approval compared with emergency use authorization, the Food and Drug Administration exists to make sure that our food and drugs and devices are safe for the use of Americans. And it is focused first, actually, the origins of the organization was for safety, and then ultimately, of course, for effectiveness or efficacy. Approval from the FDA requires multiple steps that includes what are called preclinical data. So the study of the device, drug, or vaccine in the non-clinical individuals, so usually healthy volunteers or other such situations. Then clinical data, which includes information in a variety of different settings of people who have the diseases and look at outcomes related to those. And the approval is not just based on the effectiveness and safety of a drug or a vaccine. It's also based on the ability to manufacture it to the standards that guarantee that it's going to be at a certain level of quality and reproducibility. So as you mentioned in the beginning there, Kat, the Pfizer 2-dose messenger RNA vaccine just got its FDA approval this week. Yesterday it was announced, and that's obviously welcome news. Emergency use authorization is a different category. It is also managed through the FDA, but it's actually when the Secretary of Health and Human Services determines that there is an emergency, and using available evidence, a device, a medication, or in this case, a vaccine, can actually receive use authorization because of the emergency and because the overall effectiveness and safety of the available data support the use of something. So as everyone may recall, the 2 messenger RNA vaccines against SARS-CoV-2, preventing COVID, and the 1 additional shot vaccine that was by Johnson & Johnson, all had received emergency use authorization and been available to us since the end of last year. The Pfizer vaccine is now the first one to have full FDA approval. But as we all know, the data are ongoing. We're looking at all of this, and obviously there's additional interest in approval for the use in children under ages 12. So there's more information coming, more approvals that are awaited, and even more emergency use authorization that may be put in place.
Thank you, Dr. Rubin. And in follow-up, you described some of the names of the vaccines that are currently available. Can you quickly describe to us what those differences are in terms of how they work? And share with us, with our community, what is the Foundation's position on IBD patients being vaccinated?
Well, let me start with the Foundation's position. The Foundation has recommended, based on the GI community and the advice of its expert advisors and scientific advisors, that all patients with inflammatory bowel disease be vaccinated against SARS-CoV-2 to prevent COVID and to prevent illness from that, and has supported that recommendation. The messenger RNA vaccines actually use a nanolipid, a very, very small drop of fat, essentially, to deliver a messenger RNA component to our own cells. Messenger RNA is part of what triggers the cell to then make protein. The nanolipid is otherwise inert and dissolves. The messenger RNA does not last. Despite some of the misinformation that exists on the internet, this does not become part of your genetic code. It's not reproduced. It doesn't end up in any other cells than the ones that are initially exposed. The cell's machinery uses the messenger RNA to ultimately make a protein that is expressed by the cell. The body detects that protein and develops antibodies against it. In the case of the vaccines that we're using against SARS-CoV-2, the protein of interest is related to the spike protein on the coronavirus. So these coronaviruses are called coronaviruses because they have those spikes that make them look like suns. That's why it's called corona. And the spike protein is the target of these vaccines, and therefore the antibodies our own bodies make from a protein that it has our cells make, then target those spike proteins and are able to mount a response and prevent us from getting sick from the virus. Note that it doesn't necessarily prevent us from getting infected. There's a difference, and we're going to talk about it tonight, between infection, illness, obviously hospitalization, and death. There are many different outcomes of interest. But what a messenger RNA vaccine does is it triggers our own cells to make the protein. Our body reacts to it by developing antibodies against it, and hopefully some memory of those antibodies so it can react in the future as well. And the messenger RNA goes away. Everything that delivered it goes away. There's nothing left in your body. All the other things that people are claiming on the internet or elsewhere is actually not based on the science. What we also understand, and is important to remember, is that these were not developed in the last year and a half. The messenger RNA mechanism for vaccination started almost 15, 16 years ago after the first SARS epidemic, which occurred in 2002, 2003. And they've been working on it ever since then. There's a lot of research that went into these. So the 2 messenger RNA vaccines, one is Pfizer, one is Moderna. Those are 2-shot vaccines. The other one is the Johnson & Johnson vaccine. It's a single shot that uses a different mechanism to trigger our body to react again to a spike protein. It's a non-replicative virus that is used to deliver the protein. Again, goes away, doesn't stay in our bodies, but the protein triggers an antibody response, and that's the 1-shot vaccine. We'll get into some other details about that from my colleagues in a bit.
Thanks, Dr. Rubin. And I'm going to jump to you, Dr. Caldera. Can you explain the recommendations recently made by the CDC on COVID-19 additional dose for immune suppressed patients?
Yes, I'm glad to. And first of all, thank you for having me again. It's a pleasure. And maybe I can even take a step back, because when we talk about the CDC, at times, it's this group that it might appear no one knows about, but this is a very public group. It's a group called the Advisory Committee on Immunization Practice, and they've been around for quite a while. And their whole job for some time, they used to only meet bi-yearly, but now they've been meeting more often, was to provide the CDC with recommendations of who should get what vaccines. So they've done this for vaccines that patients with IBD know about. We got a new shingles vaccine, and they made specific recommendations a couple of years ago. And at times, they made specific recommendations for patients who are immunosuppressed or on immune modifying therapies. So they follow the science. And back in July, they started reviewing science showing that certain immunosuppressed individuals, specifically solid organ transplant recipients, weren't able to mount an antibody response after they finished their mRNA series. And obviously, this was concerning for the ACIP, because unlike patients with IBD, there are certain immunosuppressed groups that can be at risk for severe COVID. So because of that, the FDA made an amendment, and they said, we recommend providing patients who are solid organ transplant recipients or have the equivalent level of immunosuppression, that most of our patients with IBD are not on those type of therapies, a third dose. So basically the FDA said, these patients can get a 3-dose series. Thankfully, we have great data from Prevent IBD, Corral, and other studies showing that the vast majority of patients with IBD are able to mount a vaccine response. But then after the FDA meeting, the ACIP met again, because that's their job. Their job is to give recommendations. But they do a great job, but they have a very tough job where they can't give specific recommendations for patients with RA, patients with IBD, and everyone's different. And they use the definition of moderately to severely immunosuppressed. And this came from a book called the CDC Yellow Book and General Principles of Immunization. And these are things that the CDC states, like who can get a live vaccine, because most patients with IBD know that if you're on immune modifying therapies, you shouldn't get certain live vaccines. So they use this definition to say, if you're on these therapies, because thankfully we have good data for patients with IBD, not every disease state has response post-immunization after the COVID vaccine. And they said these patients should get a 3rd dose out of caution to make sure that they mounted antibodies. And that's where all this came from.
Thank you. That's very helpful.
I want to add just to Dr. Caldera's great explanation, just a couple of points to drive home. The vaccines that I described are not live virus vaccines. They contain no part of the actual SARS-CoV-2. So there's not a risk, even in those who are most immune compromised, that they're going to get COVID from the vaccine. So we should dispel that myth as well. That's very important. And I hope that was clear as well in Dr. Caldera's explanation.
Thanks for clarifying that. And to dive deeper into the immune suppressed discussion. So Dr. Rubin, in follow-up, are IBD patients immune suppressed, and should all patients receive additional doses of the COVID-19 vaccine?
Well, that's sort of the crux of what we're getting at tonight. So the first thing to understand is that inflammatory bowel disease is a condition of an overactive or unregulated immune response in your intestines. So what's happening in your gut, whether you have Crohn's disease or ulcerative colitis, or you're a family member or a caregiver to somebody who has these conditions, is that very sophisticated immune system of our intestines is overactive. It's either being continuously stimulated by something we have yet to discover, or it's lost its off switch. So our treatments for IBD that have shown the most benefit and have changed the natural history of the disease in many patients are treatments that are designed to turn down that immune response long enough so the body can reset itself, catch up, and stay under control. Our therapies in IBD, therefore, do modify your immune system, but we have some therapies that are more systemically active and some therapies that are more targeted and either organ selective or more inflammatory selective, meaning they work where there's inflammation, but not on the rest of your body. So the answer is that while some of our patients with inflammatory bowel disease are definitely on treatments that reduce their immune response and increase their likelihood of getting some infections, many of our IBD patients are on treatments that do not have that effect at all. And one of the most important messages to remind everybody, and I think that the foundation has done a good job sharing this information, is that all the studies that have looked at COVID in IBD patients around the world have continuously shown that patients with IBD are not at higher risk for getting COVID, and they're not at higher risk for having worse outcomes, with a couple specific exceptions. One is high-dose steroids, which are immune suppressive, and that means more than 20 milligrams of prednisone a day for more than 2 or 4 weeks. And secondly, people living with active disease. Some of the more recent studies have suggested that if your IBD is very active, you also might have worse outcomes from COVID. All the treatments we've been using otherwise in the setting of COVID have either not had any worse outcomes or in some specific cases, and you've heard me say this before, maybe actually protective against the worst outcomes from COVID. So we can get into details about the different treatments that'll come up as we go through the rest of this conversation, but I wanted people to have a better understanding of this when they're thinking about whether they're at increased risk for bad outcomes and also whether their therapies are somehow putting them at risk for COVID. They are not.
Thank you for that clarification. And another point that's been actually confusing for people is the difference between additional dose and booster shots. So Dr. Butra, would you describe to us what is the difference between an additional dose and a booster?
Absolutely. So thank you very much for having me today. And this is a point that's very confusing because we're seeing a lot of people who are saying, I heard that I'm supposed to get my booster. And that's not what has been discussed or what has been approved at this time. And then there's confusion. If I got my third dose, is that the same as a booster, and all of this sort of stuff. So to be very clear, the additional dose implies, as Dr. Caldera had pointed out, that the standard dosing, with the standard dose, the standard 2 doses of the mRNA vaccines, the single dose of the J&J vaccine, you really never reached the effectiveness we expected with the vaccine. And this, again, is what we've seen with organ transplantation patients. And it's really interesting that during the CDC's and ACIP's hearing, they actually showed these different patient populations and where the antibody levels were with respect to the general population. And with just general immunosuppression patients, there was a lot of clustering around where the general population was, with a little bit of a tail that was down below. But with organ transplantations, they were much lower. They just didn't really reach that level that you would see with 2 doses. So the idea being, a 2-dose regimen wasn't enough. They needed a 3-dose regimen, as Dr. Caldera had pointed out. We have not seen this in IBD, and we can talk about some of these studies a little bit later, but we haven't seen these with our IBD patients. And in several real-world studies, we've seen IBD patients, even those on immunosuppressants and biologics, reach that same level of antibodies of the vaccine that the general population does. And to be very clear, antibodies are not the end-all be-all of a response a body has with the vaccine. It certainly isn't the only way to measure the effectiveness of the vaccine. So a booster implies that you did reach that level of effectiveness, but it's waned over time. It's the same as thinking of a tetanus booster that we have patients get, or pneumonia boosters that we have patients get. And it's also really important to note that a booster is something the White House has came out saying that they think they are suggesting we need to have after it's been 8 months or longer from when you finished your vaccination series. But at this time, we don't have FDA, CDC, or ACIP approval or recommendations. It makes sense, but I think it's important to wait for real guidance and real approval, because this is, we should follow the science, and we should follow the recommendations. So right now we're just talking about that third dose, and that third dose in those populations is because with the first two doses, they just didn't mount the same response as everyone else.
So, Dr. Butra, just to clarify then, are there IBD patients who we should be considering a third dose based on available data?
So according to the recommendations the ACIP came out with and the CDC said, they put TNFs and they put biologics, which is a very wide description of a number of medications. They specifically said anti-TNFs and maybe like our azathioprines or thiopurine, anti-metabolite medications. Again, I think that saying immunosuppression, as Dr. Caldera said, it's a wide swath of people. And there's a lot of variation in there. It's like saying Americans. Americans are very different, and there's different types of Americans, and they do things differently, even though we're all Americans. And so I think it's very, technically, yes, these patients have been listed by the FDA and the CDC as saying, yes, you can go and get a third dose. We can talk about, I think we'll talk about in a couple of questions later about the specific studies in inflammatory bowel disease patients, where we've seen that even our IBD patients on those medications are responding just as well as the general population. They're responding beautifully. Now, I do know that some of my colleagues in other fields who use similar anti-TNF medications, they're not seeing the same responses we're seeing in IBD. So there may be something different about the dose we use, the amount we use, the IBD patients in general that differentiates them and makes people, for example, who take biologics not all the same. And that's really what we have. That's what we have. Science is evolving. We follow the science. This is where we stand.
Helpful, thank you. And in follow-up, do you need a doctor's note to get either an additional dose or a booster shot?
No, you do not. Anyone can go in and say, I would like to get my third dose. I'm on immunosuppression. I'm on this medication or that medication. Not only do you not need a doctor's note from us, the pharmacists do not have to check to see that you actually are wherever you're getting your vaccine. We are getting a lot of phone calls. I appreciate patients reaching out and asking always, but technically, no, you do not.
All right, and just for those who are joining us now, a reminder that you can always contact our IBD Help Center if you have questions after this program, and this program will be recorded and made available later. So don't fret if you've just joined and missed out on some of the conversation we just had. All right, I'm going to move over to Dr. Caldera and ask, with the latest announcement of full approval of the Pfizer vaccine, so how can patients make the right decision on which vaccine to receive?
I think it depends. If you're someone who's been waiting out and saying, I'm not going to get vaccinated until I get something that's fully approved, then I would say go ahead and get the Pfizer vaccine, because we're probably at least a month or more from getting full approval for Moderna, and probably a lot longer than J&J. But if it shouldn't change what additional dose you should get if you got an mRNA series. So if you got the Moderna, the current recommendation is your third dose should be a Moderna vaccine. If you had the Pfizer, your third dose should still be the Pfizer vaccine. And thankfully, we live in a country where there's plenty of vaccine and people can make that choice. So I think only for the people who are waiting out, and I have a couple of my patients I need to call and see if they're ready to get vaccinated now. I don't think it changes for the majority of people.
Great. And what about patients that received a single dose of the Janssen vaccine? What steps should they take related to the additional dose? And I know that there may be data coming on that as well.
And this is a tough issue because currently right now, we don't have any guidance. The ACIP has been very clear that they know there's a lack of guidance for this. And this could go many different ways. People might not remember, but actually Johnson & Johnson was being evaluated as a 2-dose series. The reason they were evaluating only a 1-dose initially was the way you end a pandemic is by vaccinating people once. And that way you could vaccinate more people, it would be easier. And that's why they initially chose a 1-dose series to begin with. So we don't have guidance. I personally am telling my patients I expect, there's a meeting a week from now, a 2-day meeting for the ACIP, the full day. So there's going to be a lot of data that they're going to go over. I'm hoping they're providing some guidance at that point, but I am personally not telling my patients to do anything just yet, because I really want to see what the data is telling us before we're providing them recommendations that are not based on science.
Great. And Dr. Rubin, we've been getting a lot of calls on what Dr. Caldera just touched on, which is, if I got one vaccine, can I get the additional dose of another? So I think we've gotten so many questions, it's worth repeating it. Can you weigh in on what the guidance is there? And then speak a little bit about just the timing in between vaccines. Should you hold on having your IBD medication? What is the timing recommendation there?
Okay, so let me summarize a couple things and answer your questions. The first one to understand, as has been mentioned by my colleagues, is that we now have multiple studies here in the US and in other parts of the world that show that patients with IBD on their therapies have an immune response to the vaccines that is similar to people who are not on therapy. In other words, these vaccines work well in our patients with IBD on their treatments. The exception is high-dose steroids. So it's important to make sure people understand that. Number two, if you have IBD, you're not inherently at higher risk for getting COVID. I've said that already tonight. It bears repeating. Number three, the concept of getting a third dose is based on the information that has accrued that some people didn't respond fully to the vaccines or have completely lost response, and then it becomes considered a booster, as you heard Dr. Butra nicely explain. We don't see that in our IBD population yet. So we understand why this is confusing. It's been challenging for everybody. And the ACIP's recommendations are based on what they're trying to do to protect people who are vulnerable. And we want to make sure people with IBD understand they're not the same as patients with cancer on chemotherapy or organ transplant patients. Now, in regards to the questions, should you get a third dose of the same vaccine you had? If you had Pfizer, you stick with Pfizer. If you had Moderna, you stick with Moderna. Or can you or should you mix and match? The reality is that if you actually have waning immunity and you're getting a booster, the third dose of the same vaccine makes good sense and will work beautifully. The concept of getting a third dose, if you have had a normal response, the recommendation is you get the same one. We don't have data on mixing and matching, whether there's any benefit to do so. My suggestion to my patients is stick with what you had before. I will also add that in terms of your medications, we do not recommend that you hold your medicines or time your vaccine differently from those medicines. There has been in the rheumatology community the suggestion of perhaps holding methotrexate or holding tofacitinib. We haven't seen that has been an issue in the IBD community, and we haven't made that a global recommendation overall. So the bottom line is to make it easy, stay on your medicines, stay in remission, and get your third dose or ultimately your booster at the time that it's available to you. Did I leave anything else out? Oh, one more thing. If you're going to get a third dose and it's been suggested to you that you need it, or you talk to your healthcare team and they recommend it, it should be at least 28 days after your second dose, but in general, we're saying longer than that. Did my colleagues want to add anything to those statements? I don't want to confuse more.
I do think that there are currently studies and results are expected in the next few weeks. First of all, about the J&J and what to do specifically about that. And then also there are trials that are concluding and data being analyzed. And again, recommendations in the next couple of weeks about mixing. So is there benefit to mixing or not? But as Dr. Rubin mentioned, the current recommendations are stick with the vaccine series, your primary series that you got.
The vaccines are working in our patients. And the difference between getting infected or being contagious versus getting sick or hospitalized or, God forbid, dying. All those outcomes, thankfully, in people who are vaccinated are not something we're seeing, and certainly not in our IBD population.
Another thing that's been on our patients' minds are breakthrough infections. So, Dr. Butra, what guidance would you give an IBD patient that had a breakthrough infection, meaning vaccinated but did get COVID-19? What guidance would you provide there?
So let's start first of all from a practical standpoint. If you live currently in an area of substantial or high transmission, and you can go to the CDC's website and look this up, pretty much it's the entire United States right now. It is recommended you wear a mask in indoor settings and in crowded outdoor settings. If you have COVID-19 symptoms and you're fully vaccinated, you should get tested. If you come in close contact with somebody who had COVID-19, and you were fully vaccinated, it is currently recommended you be tested 3 to 5 days after the date of exposure, continue to wear a mask for 14 days following that exposure. And if you test positive for COVID-19 and you've been fully vaccinated, these breakthrough infections, you should isolate, quarantine for 10 days or as long as you're experiencing those symptoms. So that's the practical recommendations. But now people are really worried about breakthrough infections. And I think I want to just piggyback on something that Dr. Rubin had started to say, which is, what is the goal of our vaccine, right? I'm an epidemiologist as well as an IBD doctor. And what worries me most is those severe disease and death. And we know that all of our COVID-19 vaccines protect against severe disease and death, even now. Even if you got your vaccine over 8 months ago, especially, as Dr. Rubin said, even if you're an IBD patient, regardless of what medication you're using. However, it feels like as a community, as a public, as a country, they have considered the goal of a vaccine as preventing any COVID. And I think it's really important to note that no vaccine does that, right? Even the very first day you were fully vaccinated after you got your COVID-19 vaccine, everyone's cheering and you're excited, you were not 100% protected against getting COVID-19. Our flu vaccines in their best seasons are about 50 to 60% effective against the flu. That doesn't mean that we stop and get flu boosters or anything like that. We know that even if we get the flu, we are protected against severe disease and death. And the same holds for our COVID-19 vaccines. And this is important because, we know, I hope if anything, COVID has taught us that we live in a global community. And in our global community, over 80% of our vaccine has gone to about 20% of the people. And if we keep vaccinating and giving these doses to the same small proportion of people over and over, we're really not protecting ourselves. Variants are going to continue to emerge among the unvaccinated. And for example, that's how we got the Delta variant. So remember, the vaccine is not your only protection against COVID. And if you really want to avoid those breakthrough infections, I think of it like if you go out into the rain. If it's just a light rain, take your umbrella. That's your vaccine. You might get a couple little drops, but you're going to be fine. You're not going to get sick. But if it's a rainstorm, we put on a raincoat as well, right? And that umbrella is not going to be good enough. So during these times of high community transmission, the mask is your raincoat because there's more COVID around. So instead of just saying, I'm going to get another vaccine, I'm going to get another vaccine, I'm going to get another vaccine, we can do these secondary prevention measures. We can wear masks. We can avoid crowded indoor settings. We can avoid crowded outdoor settings until that storm passes, and Delta will pass. I promise you it will. I understand I'm an immunosuppressed IBD patient. I think I've been pretty open with the IBD community about this. I understand these concerns and fears. I am currently not getting a third dose because I know our studies and our science and shows that I am not one of those people who didn't respond well to the first 2 doses. I am protected. And I know that my community currently has high transmission, like everybody else in the United States. So I wear a mask. And I know I'm even more protected than I was before I got vaccinated from getting a breakthrough infection, from passing COVID on. But I was one of the first people to get the vaccine. I'm a hospital worker. If and when these boosters get approved, I will probably be one of those people who it's recommended gets a booster early because I will be well beyond 8 months from my vaccine. And I will do that. However, even with the booster, I will still always mask up. In the hospital, I will still continue to wear a mask if there's high community transmission, because again, not even with the booster will it be 100%, effective at preventing all COVID. At a certain point, I just want us to stop living in fear. We can learn to live with this. The most effective way is not with fear, but rather with public health and prevention. And that's not just solely vaccines. And I hope that we as a community can feel a little bit more secure that we've done the right thing with getting vaccinated. Highly recommend you do. And you've always got a mask.
So first of all, I want to thank you for sharing your personal story publicly and for working so hard in vaccines and the work you've done for the flu shot in other parts of the world before we had a pandemic. I want to acknowledge that incredible work you've done. But you made a comment that I want to clarify for people, which is you said, I know I'm not one of the people who didn't have a good response to the vaccine. So who are the ones who should be worried that they might not have had a good response to the vaccine?
I'm not on high dose steroids, I think, and I don't have active disease. And right now, those are the people, as you had mentioned, who are at the highest risk for getting COVID, or are the ones who probably are in that community that are on par with our organ transplant patients who would not have mounted as strong a response to its 2-dose series and may need a 3rd dose. I don't fall into those criteria. I don't feel that I'm one of those people who needs to go out and get a 3rd dose right now.
So if I might, Dr. Caldera, I want to ask you about titers. One of the things driving some of the conversations are whether or not people who have antibody titers have waning or reduced antibody titers over time, which is what's leading to the conversation about a booster, or undetectable antibodies, which is the conversation about a 3rd dose. So if you could first start by telling people what a titer is and what antibody are we talking about? And does that apply to the IBD community? Should people want to have their titers measured? Can you just provide some clarity for people on that one, Freddie?
Yeah, thanks. This is a great question because a lot of people have personally asked me even before some of our studies like Prevent COVID and Corral came out, and we're doing a study at UW even looking at this question too. So every vaccine prior to COVID, the way the studies were normally done is you would get antibodies where you would measure this prior to vaccination, and 2 to 4 weeks after the vaccination, you measure how your body is responding to the vaccine, and do you make antibodies. But your immune system is complicated enough that we have something called B cells, we have something called T cells, we have something called memory B cells. And measuring an antibody at a random time point might not be predictive of whether you're immune or you're not immune. And it gets more complicated. Just like we got an emergency use authorization for the vaccines, we got emergency use authorization for these COVID antibody tests. So, anyone could go and sign up and go to any lab and get a COVID test, but you might be getting a COVID test that looks for an infection rather than immunity. So that's something called an anti-nucleocapsid. The studies where they've looked at vaccine response, they're looking at something called receptor binding domain. And you see if you make antibodies. Then it gets more complicated because there's something called the spike protein of the coronavirus. And we really don't know, where an antibody should be. And, we don't know where this immune level should be. It might not even be antibodies. With viruses, T cells are very important. That's where we're going to learn a lot more. And even when we're looking at most patients with IBD are probably around 4 to 5 months post-vaccination. And it might be that you can measure antibodies and they might be not measurable because you're using a not reliable test or because the test is not good enough to pick this up. So it's not that we don't want to provide these answers to patients, but kind of just like Dr. Petro said, we have evidence that vaccines work. Getting a test that might come back negative could have big repercussions for a patient if you perceive that test tells you you're not immune, or if you say, well, my test was 2 compared to 100, because the 2 might be great. It doesn't necessarily mean it needs to be 100.
Yeah, there's an emerging study from Russia, actually, looking at people living in Moscow that showed that any amount of measurable antibodies were likely to be better than nothing. And there wasn't a high threshold versus a low. So I think that it's important for people to know. So should they get their antibodies measured? I'm hearing you say no.
Definitely not. I would not recommend getting outside of a research study, having someone measure their antibodies, because it's not being done the way they were done in the clinical trials. And you're getting at a random time point. And right now, if you have antibodies, great. But just because you don't have antibodies doesn't mean you're not protected. Because
and to echo what Dr. Keldra is saying, at the CDC ACIP hearing to approve the 3rd dose, they made very clear on multiple occasions they do not recommend people going to get antibody measurements to make this decision. That is not the way to determine this, for all the reasons that Dr. Keldra is saying.
So in a really well done study in the UK, they describe patients with inflammatory bowel disease who were on anti-TNF therapy compared with people who were on another drug, vedolizumab, which is not an anti-TNF. It's the drug our patients will understand to be Entyvio. And the point, though, was that the people who got anti-TNF, when they got their first of 2-dose vaccines, their antibody titer was blunted, but when they got the second, it was the same as the general population, the same as those who are receiving the Entyvio therapy. Now, they've subsequently reported that the antibody titers were waning or going down over time, with the implication that that would suggest people are going to have problems if we don't give them a booster. So, Dr. Butra, can you comment on how we should interpret that? When will we know whether this is appropriate for our patients? And will the study like this be the one that will help us, or do we need to think about this differently?
Well, one study is always one study, and we need to interpret that with caution. But I also think that we don't currently have any recommendations. I'm sure this will be one of the studies that the CDC, the ACIP, and the FDA will take into a consideration when they're thinking about these booster vaccinations. Currently, as I said, the White House has said everybody does, because it's other studies in Israel and maybe a couple in Europe have indicated that other populations, not immunosuppressed, but the elderly populations, for example, have a faster waning of their titers over time. And that the time is the critical piece here. The amount of time from when you got fully vaccinated is what's really, really key. So I think we wait to see other studies that are coming out. There are certainly other studies in the field of IBD that have been completed or are ongoing. And we also wait to see what the final guidance is from the CDC, FDA, and ACIP.
And if I could just...
Oh, go ahead, please.
No, and if I could just interject is, we know from other vaccine studies that antibodies wane with time, or even from other viruses. So many patients with IBD are probably familiar with, about having chickenpox, whether they either had chickenpox disease or the varicella vaccine against chickenpox. And people might know that they might develop shingles or herpes zoster. So you could check a lab and see where your antibody is and whether, after you get a varicella or chickenpox vaccine or infection, you develop antibodies. But antibodies don't tell you whether you're preventing shingles. So you could have really high antibodies and not be protected against the varicella reactivating. Because what we really need, we need what's called a correlate of immunity, or a fancy way of saying, what do we need to check in your immune system, either an antibody or a T cell activity or measure. We don't know what that means before. So while I think we might see other studies showing that certain patients with IBD on different immune modifying therapies may have lower antibody concentrations, I don't think we're ready to interpret that as saying you're less protected.
I was just going to ask about IBD patients who also have a comorbidity. I think we talked a lot about the medications and the data around that, but is there any recommendation for those that have other comorbidities like cancer?
Well, one of the things that we think about when we're talking about whether people should get a third dose or ultimately whether they're going to be eligible and need a booster is not just whether or not their immune system is responding to the vaccines. And I think you've heard from our colleagues tonight that the available data we have in IBD, with the exception of high dose steroids, shows that you responded well to the vaccine. But also, what's the risk to the individual if they get COVID? And as I started by saying, patients with IBD who get COVID do not have any increased risk because they have IBD. They have the same risks as the general population for having bad outcomes from COVID if they're unvaccinated, if they're over age 65, and if they're obese or have diabetes, hypertension, or heart disease. And you asked about cancer, so presumably you mean somebody who is receiving chemotherapy or is otherwise compromised. So the decision about getting a third dose now or a booster later will also be based on what is the risk to you if you were to get COVID. And notice I started by saying that if you're unvaccinated, that's the number one risk. So get vaccinated. The second part of it is then, of course, are you at risk to have not had an appropriate immune response? Well, you heard tonight that almost all the IBD patients have. And then what's the need for you to protect yourself otherwise because you have these comorbid problems? And that's what we need to remind people, that because you're not an increased risk for bad things from COVID, you're not a decreased risk either if you have those other risk factors that have been well described from the earliest days of the pandemic.
Thank you. And let's transition a little to children. So children 12 and up that have received the vaccine, are there any special considerations around booster shots that parents should think about? And what guidance should we give parents with IBD patients to send their child off to college?
Yeah, so
directing that question to Freddie. Yes, please.
Yeah. So glad to answer it. My disclaimer is I'm not a pediatrician, even though I have 4 kids and I don't provide advice to them. But I think, Dr. Breacher said this beautifully where, if you have a child that's going to college, we all went to college at one point. And you can, as a parent, you can have the reassurance that the vaccines work. You can have that reassurance. I guess what I would tell my child would be, it's kind of like all these terms we're learning during the pandemic, right? Layers of protection. I have 2 kids under 12, so I hear what we're doing to keep them safe at school, and I would be just hoping that you're doing all the right things where, at University of Wisconsin last year, our school campus was undergoing testing routinely. And you want to make sure you have these different layers of protection where you have either routine testing that's being done, people are wearing masks, but first of all, make sure someone gets a vaccine because that's what prevents severe disease.
So a teenager who's been vaccinated and has inflammatory bowel disease and is on medical therapy for their inflammatory bowel disease, do they need a third dose at this time?
If they were on high-dose prednisone when they got vaccinated, I would say yes.
But they weren't. Let's say they're doing well, which I hope all children are, but let's assume they are in this scenario.
I would say unless they were on the anti-TNFs, but if they're like on ustekinumab or Stelara or vedolizumab or Antibody, I would say not now.
And if they're on anti-TNF, I think it's important we drive this home so people understand the takeaways here. Are you recommending a third dose at this time?
I am.
Okay. And that goes for the adults on those therapies?
Yep.
Okay. And what about kids under age 12? Dr. Butra, do you want to take that one since I know you have a couple of those?
So first of all, I just want to say that we still have less than 50% of our 12-year-old to 18-year-olds who are vaccinated. We are starting the school year. Parents, please, if your child is not vaccinated yet, please start that now, because they will not be fully vaccinated before school starts in all likelihood. But this is the single best way to protect them and to help protect their classmates and their schools and their communities, their college campuses, et cetera. If they're under the age of 12, unfortunately, we do not have vaccines that are approved yet. There are certainly trials that are ongoing. Hopefully before the end of the year, I think is the most conservative measure that we have for when these will be approved. I absolutely sympathize with every parent who pretty much texts me or tweets me about once every couple days and says, what's the new update on this? I want my kids to get vaccinated as well. As soon as they can, I will be there, and I certainly hope all parents will also. Until that time, it really is masking. And remember that masks are recommended for 2 years old and up. Please don't be afraid to ask your schools if they have a mask policy. We know our school district has publicized what percentage of staff are fully vaccinated, and what the staff that are not vaccinated or don't want to give that information out, they're undergoing twice weekly testing. What is the spacing? How are they eating lunch? What is the ventilation? There are all these other secondary measures that we know can work and that can be implemented. And you certainly can have that, for your children. And remember, even if there's not a mask policy, that doesn't mean your child cannot not wear a mask. They can still wear a mask to school. And my children have been in the situation where all the kids around them were not wearing masks. And I explained to them, I said, it's really important. I don't want you to get sick. We've come so far. We've worked so hard. I don't want you to get sick now. And they understood. They wore their mask their entire time. They were good with it. Kids are so much better than adults at this. So please don't be afraid to implement those secondary measures. They work very, very well until we get the vaccines approved.
Dr. Butra, would you summarize for us the Prevent COVID Corral Vaccine IBD study, ICARUS study, which all suggest that IBD patients that receive both doses of the mRNA vaccines mount an appropriate immune response?
Yes, I'd be happy to, and I'll actually just do this very generally because I don't want to overwhelm people. But to put in perspective, the ICARUS study is from New York City. The Corral study is predominantly from California. They're about I think Corral is up to 300 and change patients. And then Prevent COVID is actually a national study. So it's taking any patients across the country. They have over 3,000 patients enrolled, and they have data on over 2,000 of them so far. And what all of these studies were looking at was, okay, again, with all the caveats that Dr. Kelder gave us about antibody response, was looking at what was the response to the vaccine in these IBD patients. And very specifically, Corral, ICARUS, were looking at patients who were on immunosuppression, anti-TNFs, the other biologics that we have, anti-metabolites, et cetera. Prevent COVID was open to everyone, and well over 90% of their population are on immunosuppressants. And the largest proportion of that are the anti-TNFs. What each and every single one of them showed is that patients with inflammatory bowel disease, even those on these immunosuppressant medications, after their second, when they were fully vaccinated, not over 90%, and some would say 95% plus, had mounted an antibody response comparable to what we would expect in a non-IBD, non-immunosuppressed patient. So again, telling us that at least for our patients, it can give us reassurance that they are responding to these vaccines like the general population, not like these organ transplantation patients or maybe other patients who are immunosuppressed in other fields that we are worried about with these, who might need these third doses because they didn't have that same response. Now, the Prevent COVID is still ongoing because they're going to look at longer term data. But just to sort of summarize the lay of the land, and all of this is public data, it's all out there. There's certainly studies that have been published, and folks, I think the foundation has some of those studies actually on their webpage as well.
So I just want to clarify, I'm going to ask you guys to make this clear for the audience, which is the distinction between the ACIP guidance and Dr. Caldera, you've been part of that process about people on anti-TNF specifically getting a third dose versus the reassuring information you just heard from Dr. Butra that we in the IBD community have seen appropriate immune responses. So how does the audience reconcile that, and what's the final say in terms of what are we recommending? So Freddie, maybe you start.
Yeah. So anyone who saw me on Twitter knows that when this initially came out, I was very vocal for a very specific reason. Before we knew boosters were going to be this soon, because we got to read the room. Boosters are coming, just like we get a flu shot, COVID-19 vaccine boosters are coming. What I originally didn't want people to believe and perceive is if we were all saying, yes, let's give everyone a third dose, from a patient's perspective, you might be led to believe that the therapy you were on interfered with your immune system responding to the vaccine. While PREVENT, CORAL, and all the IBD studies are good, and we know that you're able to initially mount an immune response, the big unknown is, could these therapies affect, whether it's antibodies, whether it's T cells? That's the unknown yet. So from my standpoint, when you look at the ACIP guidance, I agree that since we're going to be providing boosters to the general population, I think we should provide boosters to our patients following the ACIP who are on anti-TNFs, metabolites, or who were on prednisone, either close to vaccination or still on prednisone. So I think we should be providing that third dose. Obviously, when the general population gets boosters, or whether there's a different time window in other patients, I think the ACIP will provide good guidance regarding that. And I think that aligns with the Crohn's colitis current position statement.
So for patients who are on anti-TNF therapies or azathioprine or 6-mercaptopurine or perhaps even tofacitinib, these are people who should get a third dose, or would you just call it a booster now based on
based on what we know, it's probably going to end up being a booster.
And the distinction between what we call them, I hope, has been clearer tonight with this conversation, that the population is going to be recommended boosters, we expect it's coming, and therefore people who qualify now can get them, but we want to reassure everyone that your immune response, with the exception of high-dose steroids, has been what we would hope and what is similar to those who are not on therapy. And it's important for people to be reassured by that, as Dr. Butra said, to not be living in fear. The vaccines work. We have data in IBD across multiple studies that show that they've worked in our patients. And so getting an additional dose now, which we're telling people is likely a booster and not a third dose because you didn't respond to the first two. We have no data to say that that's happened in our patients. Seems reasonable, and it's going to be coming anyway, so you can move forward with that. Is that a good summary of that, Freddie? Because you've been very close to this from the ACIP side of things.
Yeah, definitely. And one thing I think, that we're lucky is we have great people doing research in IBD who are helping us get some of this data. We have great people in the foundation that work tirelessly to give our patients this data. All the people that you probably never heard about, and we have great leaderships, that help inform our patients. That way, no one's stuck like in March 2020, where it was a scary time for anyone who was on immune modifying therapy or immunosuppressed.
Yeah, I have to say that I, of course, always loved being a gastroenterologist, taking care of people with IBD, and loved my colleagues. But I am incredibly proud of the international collaboration that the IBD community demonstrated during this time. And in many ways, other disease states and immune conditions modeled their studies after what we were doing in the IBD world. So it's really been a privilege to be a part of that, but also to learn from my colleagues, and for our patients to know that people are working together in really incredible ways to get the answers we need and to continue pushing forward to protect them.
Well, that is a great message to wrap up the evening. We've reached the end of the program, so thank you very much, all of you, for your expertise and openness and helping our community better understand just what to do and how to think about all the guidance that we're receiving.